This is Community Access National Network's 7th annual monitoring report on HIV and HCV co-infection. We are partnered, again, we're partnered with Help HIV, and this is a pre-synchronicity 2022 session. My co-presenter today is Marissa Tonelli from, did I get that right, Tonelli? Perfect. From Health HIV. Marissa and I have done this report last year. We did it together and it went really, really well. I was very happy with it. So this is a fantastic opportunity we hope to continue to do. This session will be recorded. So if you don't want your voice or face associated with this, then I would encourage you to either email us after the fact or reach out if you want to continue conversation. That said, I am Jen Laws. I am the CEO of Community Access National Network, and we will begin the presentation now. So I want to start with a special thank you to the folks who made this happen, our sister organization, ADAP Advocacy Association, and our funding support from Gilead, Janssen Pharmaceuticals, Merck, and ViiV Healthcare. Without the support, generous support of our funders and our partners, and frankly, our participants, this monitoring report wouldn't go very far, and we certainly wouldn't be able to help keep y'all up to date, informed, and engaged. So this is an update. This is being the 7th report. This is not the first one. However, this is quite reflective of the HIV/HCV co-infection watch that Community Access National Network hosts. It's a quarterly report, and you can check it out at hiv-hcv-watch.com, or you can go to TIICANN.org for more information about Community Access National Network. I have no conflicts of interest to disclose. As of July 2022, which is our last report, the national will be coming out in October. You know, there's this amazing growth in AIDS drug assistance programs adopting direct-acting agents, curative direct-acting agents for hepatitis C infections. This year was kind of cool. We added Idaho as one of the ADAPs there. And the AIDS drug assistance programs really are kind of crucially important. There are estimates that up to 30% of people living with HIV also have experienced a hepatitis C infection at some point in time, or are currently living with a chronic or acute infection. The expansion of the AIDS is not necessarily just one drug at a time. A lot of times it's diversification of drug options that'll help address different genotypes of HCV, and these expansions are really kind of important in terms of long-term health care and long-term health outcomes for patients, especially the most marginalized patients, and especially as we're looking at that intersection of HIV and HCV co-infection. Mavorixafor has become one of the fastest and most well-adopted curative direct-acting agents in this space. The VA uses them almost exclusively. It's one of the most start spaces in terms of making sure that patients have access. As I mentioned, Idaho adopted DAAs as an expanded coverage metric for AIDS drug assistance programs this year. Now, Texas did something really interesting last year, and I think it's something that we need to keep an eye on. Is they removed our base level medications from their ADAP formulary. They also reduced every one of their DAAs down to CLUSA only. They are not covering anything else. The Georgia ADAP website maintains, and they have since the COVID outbreak and an influx in patients and reduced funding, that while hepatitis C DAAs are included in the formulary, they are not covering them right now. So that leaves a gap in coverage for people who are not Medicaid qualified, but can't afford medication to deal with their HCV diagnoses. This map is really just a visualization of that expansion. A lot of this advocacy is based on our state advocates. You guys are rocking. This is awesome. But there's still some gaps there. I'll note that Vermont's a really interesting place because one of the reasons they have not expanded ADAP coverage of DAAs is because they have a bit of a comprehensive coverage in their Medicaid program. However, there's a gap. Medicaid is typically cut off at 138% of the poverty level, and ADAPs fill this gap for lower income people living with HIV, most typically up to 400% of the federal poverty level. So ADAPs play this really crucial role for people with a co-infection of HIV and HCV, and that can't be undercounted as we're moving through these programs and access. You'll note here in this, like there's this turn in how many jurisdictions are covering DAAs in their ADAPs. It's fabulous. We want to see more of this. We want to move away from the lack of coverage because ultimately this type of co-infection impacts health outcomes in both areas of HIV-related health outcomes and HCV-related health outcomes, increase in aging, increase in cancers, things like that. So we've got to treat people living with HIV as whole persons with multiple health issues. I really want to take a moment to talk about COVID impacts, that COVID crisis moment in 2020, and how that impacted HCV rates in surveillance. This is a pretty big deal. You'll notice that I have the 2019 data there. One of the things that Ken really highlighted in our blogs through 2020 was, hey, we're kind of flying blind. We're seeing reduction in HCV screening in emergency rooms and everything else, and this is bad. If we don't know where this epidemic and where this virus is really kind of transmitting, where we're seeing new diagnoses, so we're not going to be able to effectively intervene and treat it. Our programs are going to go like it's bad. Our programs are going to have a hard time reaching the people who need it most. So what was not surprising given the dynamics in West Virginia's 2019, we had a really kind of high rate of new HCV diagnoses, in particular associated with injection drug use. Now, because of that flying blind thing, it's not universal when it comes to the reduction in screening. You know, Maine had this massive jump in terms of new HCV diagnoses and their rate of infection. Now, what I would say to that is that they may have uncovered something in terms of our screening, and we'll get to why I think that might be the case here soon. But in other areas, we saw reduction in rate of HCV infections, and that, again, that's going to be indicative of screening, and are we reaching that event horizon and enough screening to have this being reflective. So this data was just made available last week on the CDC website. So I would highly recommend being cautious as you interpret this data and how you look at your programs. But also go check it out. I can provide a link if y'all need. This top 10 rates compared to expanded coverage piece is really kind of important. This is the 2019 data. I really need to put it out. The slide you're looking at right now is 2019 data. And what I highlighted here is that not every state reports HCV infections or diagnoses. And that's kind of problematic in big ways. So in some states where we see reporting, there's really good information on what guides our programs and what really kind of helps ADAPs in particular and Medicaid programs kind of direct their programming and their efforts. How do we do that outreach? And in states where we don't have that nationally reporting, it's not great. We can't direct programming if we don't know what's going on. So, in that there's this cross section, especially in Utah and Kentucky, where the ADAP can't engage, and that's bad. So Medicaid coverage trends from 2015 to 2022, starting, I think it was in 2019, all Medicaids covered direct acting agents, and that was awesome. Like that was fabulous. It was a beautiful program that started here in Louisiana in Washington State called the Netflix model. It's a subscription model in buying bulk direct acting agents on the state end to reduce that overall cost. We're starting to see some of the difficulties because cost of drug is not the only problem. You know, we got to be able to reach people. So the multiple managed care organization plans are likelier to offer a smaller range of DAAs, and that could be problematic as we're looking at different genotypes and different needs of different patients. So I mentioned here in this slide that Vermont ADAP is not expanded because of Medicaid expansion. I'm going to encourage states and advocates to remember that Medicaid is not the only solution. And it's certainly not the only solution when we're talking about high-cost medications or limited access, thanks to how payers institute barriers like prior authorizations, like step therapy. And we're seeing some really new and unfortunately creative barriers that these managed care organizations and private payers even are kind of throwing up. Past adherence to other prescription medications. Patients are going to prioritize their care how they choose to prioritize their care, and the paternalistic view that you should care about this the way that I think you should care about this, or more than your gender affirming care, or more than keeping your lights on or having housing, is not going to work. Meeting patients where they're at means truly meeting them where they're at and allowing them to self-determine their own care. That past adherence issue also doesn't take into account problems that patients have had. We have patients with problems, not problem patients. One of my favorite lines that Joey Wynn, I was at a meeting early on in my advocacy career, and he was shouting it out, and my heart sung, and I said, thank you, thank you, thank you, because I've been one of those patients. I've been homeless. There are times in which I have not been adherent to my medication, regardless of what it is, because I struggled. And as we're looking at issues like climate change and disasters that interrupt actual access to care, actual ability to maintain your medications, actual ability to even have safe medications because they've been ruined by whatever's going on. Those types of disruptions, as reported by a payer, lack context. They lack the ability for a patient to say, hey, you know what, I need more help now. I needed more help than I do now. So really kind of pay attention to those things, and as you're looking at your state advocacy efforts and how your programs are designed, make sure that you're prioritizing the patients should be driving their own care. We're not moving around them in a hurricane or coddling them or anything else like that. They are in the driver's seat, not the passenger seat. This is not centering them like a toddler in the back seat with a safety belt on. They should be driving it. So that issue on lost or stolen medications is going to disproportionately affect patients who are marginalized, who are experiencing systemic discrimination, who are already experiencing disparities in housing, in employment, in safe situations. So we've really got to keep in mind and how creative payers are getting at saying, nope, I don't want to treat that patient, because that's what this comes down to. Medicaid expanded coverage, here's a visualization of what we just went through in terms of who's covering what in terms of direct acting agents. Every state covers direct acting agents in some way, shape, or form. That does not mean that every state covers them equitably. The CDC issued a vital signs report earlier this year as MMWR, or Morbidity and Mortality Weekly Report. And when I'm talking about these payer barriers to care, it really kind of highlighted it, especially in terms of Medicaid. You're going to see lower screening rates on the Medicaid versus private insurance. We see that as one of the groups here. We see in terms of initiating care after screening, there's lower rates relative to private insurance. And I don't know necessarily that, like, I believe things that I know in terms of what from patient experience, that this is a lot based on the payer, but it might not just be based on the payer. There's a need for provider education to say, hey, you can't just leave this alone. You can't discriminate against patients based on their payer. We have to make sure that, yes, they are a Medicaid patient. You need to be treating them. You need to be looking for everything that they need and helping them get there. And that includes providing case management as they need it. It means providing community resources and social resources and other support to make sure patients are set up for success. Failing to do that is failing your patient. So there's also a delay in terms of when people are getting the care that they need. Because HCV can sometimes clear on its own, sometimes providers are like, let's see what happens. Gotta tell you, the clinical data ain't great for that. Your risk for developing cancer and other comorbidities as a result of an HCV infection, even an acute one, are not great. So delaying that care, hoping that a body's going to clear HCV on its own, is a bad idea. And making sure that patients know how to self-advocate, making sure that patient advocates in care settings are saying, hey, no, this patient needs this and we need to set them up for success. That's our job. I can't emphasize enough, the vital signs report was startling. Truly startling, because it reflected not just that private payer issue that we're talking about. We're talking about our core and central public health programs, our public payers. It's bad. When timely treatment for people living with a hepatitis C infection or diagnoses for Medicaid is 23%. That's bad. 1 in 5 patients, 1 in 4 patients I cannot emphasize this enough. I'm struggling with it. I would really need to get on top of that. And that means reaching outside of our traditional spaces. Not necessarily, HIV advocates are not necessarily oriented to engaging Medicaid as much as maybe we should, or even as much as we engage our ADAPs. So look for those spaces where you can engage on your Medicaid programs, because that is state determined as well. And we know how to do that. Lean into your strengths. It's just going to be with different relationships. So one of my favorite spaces to talk about is Veterans Affairs, because they've done an astounding job. They are the single most effective payer and payer source to engage their patient population with regard to HCV. The treatment guidelines have been up to date. They are quickly up to date, relatively speaking. They are actively reaching out to their patient population as a payer to say, hey, have you been screened? They're reaching out to their providers to say, you need to be screened. This is going to be one of those metrics of care that we're going to be checking up on you to make sure that it's happening. One of the other spaces that the watch looks at is harm reduction trends. This is one of those spaces that we need to put a lot of attention to, in part because it's changing. The Biden administration has decided to put an emphasis on harm reduction rather than criminalization. It's a dramatic shift in the war on drugs to really kind of empower people to make choices in that self-governing way, to move through their risk factors and understand those things, and to educate themselves and to reach out to providers and to engage in this community-centric space. Syringe service programs are one of those big pieces up there, but one of the spaces that we're seeing adopted, or at least considered in coastal areas, I'm hoping that we're going to start to see that elsewhere, is the safe consumption sites. Keep an eye on that. California vetoed it recently, but I think that's only a matter of time. Ontario, Canada is launching a pilot program that may prove to be extraordinarily interesting, and it's a safe supply program. So where they are providing these drugs that are typically considered illicit, because the counterfeit and the street drug is killing people. And one of the safest ways that we can make sure that people are monitored and cared for is to make sure that this is a metric of care, even if it's not something that social stigma tells us is great. we can keep people alive and we can keep them moving through harm reduction. That's a big deal. So social stigma continues to come up, especially as we're looking at these things, particularly among legislators. We've seen some syringe service programs shut down over the last 2 years, not due to lack of resources, not due to lack of need, not anything else, but because you have law enforcement, you have legislators saying these are terrible people, we are moralizing a health condition that is drug consumption. But that also means that we are moralizing the results of those things, including HIV infection and HCV infection, and that's not okay. At any point in time that we look at somebody and say you deserve the hepatitis C that's killing your liver because you took drugs, then we have failed our obligation. So we need to take a look at that. I want to run through real quick some of the harm reduction tools, measures that we look at, and then we'll move this off to Marissa. We don't judge our harm reduction measures in the watch. I don't tell you if they're good, bad, or indifferent. One of the reasons why my best example of that is Good Samaritan laws. Oftentimes there's a carve out for drug dealers or dispensers that says that you are not protected by the Good Samaritan law, and that is a disincentive for people who are witness to drug consumption and overdose to call for help when they need it. It's bad. So North Carolina is looking at tackling that gap there. I would encourage advocates as they look at harm reduction and these statutes, that these legislations that might be coming up, where that could be used or weaponized or criminalized against people who should be intervening to help. This is just, we've seen some of these harm reduction measures that we currently look at shift over the years. Very quickly, the physical exam piece was put on temporary hold as a result of the COVID crisis. The DEA, we expect the DEA to lift that requirement or to adjust it in light of telehealth programming around the time that the public health emergency is declared an end. However, what that looks like, we don't know, because it might require legislation. There might be executive moves that could occur to help deviate those things or to divert the potential harms of that. So right now, the public health declaration has been extended. We are expecting sometime in the next 60 days or so to hear if it will be extended again, because we've been told that we will get a warning, and that's really kind of important, especially because the continuous coverage piece associated with PHE will end when that ends, and that there is a lack of warm handoff coordination occurring, which means that there are patients who could benefit from HCV DAAs that might not get it, that might not be able to continue or complete treatment or maintain their HIV-related treatment or anything else because they're going to be kicked off. So keep out for those notices, educate your communities, make sure that your patients know that they need to be engaged in those recertifications and eligibility pieces. I talk here a little bit, or I featured a piece here on how harm reduction groups are facing local opposition. It's one of the things you should look at. Even if we make strides, we're gonna get some pushback until we tackle the stigma issue. And as I mentioned before, disasters can disrupt our opioid treatment programs. One of the coolest things that the Biden administration, I have to pin this, the Biden administration was looking at how to use the Americans with Disability Act to protect people who are recovering from opioid use disorder and substance use disorders and engaging in those programs. So that's super awesome. How that develops is great. And it's not just the Biden administration. The Trump administration did the same thing. This is when we talk about these things as partisan issues, this is a bipartisan issue in making sure that we are treating substance use as the health condition that it is. So, and climate change is going to be something that we got to pay attention to. So, better or worse, it's coming into our space, and we've got to start considering how our programs might be designed to meet those needs in situations of natural disasters. So this is my contact information. As I said, the slide deck's going to go out right after or sometime after this presentation. You're welcome to reach out at any point in time. I'd love to hear from y'all. I'd love to engage with y'all. Look how we can partner. Look how we can have feedback, how we can make things better, how we can engage on state and federal levels together. Marissa?
Great. Thank you so much, Jen. And just wanted to say thank you to everyone for inviting me to present today alongside the Monitor HIV Hep C co-infection monitoring report. My name is Marissa Tonelli. I am the Director of Health HCV at Health HIV. I also lead a number of our capacity building programs at Health HIV. And we're very excited again to be able to be a part of this and to work with this team at Synchronicity 2022, which will be virtual this year coming up in December. So we'll be able to share some more information soon. And we can go ahead to the next slide. And I have no disclosures. All right, so I know we were talking about some of the recent CDC data, and actually, what was it, Monday? No, or Friday or something. As we were preparing for this presentation, CDC released the report, their surveillance report, and released some new data. So I just wanted to go through this as a starting point from where we're working from as of today, from what we know on a national level. And as Jen mentioned, we are very, very sure, we can be very sure that much of this data is underestimated as a result in the decrease in testing that occurred during the COVID-19 pandemic in 2020. There's a number of articles that cite this. I actually put one of the references here on the slide. And I also have some anecdotal data that I'll share with you. But just to kind of highlight it, we did see, that the rates of acute hepatitis C are highest among American Indian and Alaska Natives, and that overall the rates of hepatitis C has increased at least since 2013, even if we can't say for sure between 2019 and 2020, but certainly more than doubled. 124% since just under 10 years ago. So it is quite, certainly quite going up, and we're not quite sure how much more, just due to the fact that there was such decreased testing. We also know that there are highest incidents among people who are aged 20 to 39, so slightly younger than the baby boomer population that has been a focal point, at least from the prevention and testing standpoint. And also that 2/3 of the cases that reported risk information reported injection drug use. And so we also can say with certainty that since 2013, the increase in injection drug use has certainly contributed to the increase in newly reported cases of Hep C. So we can go to the next slide here. Great. So I just wanted to show again, again from this data that we're seeing that viral hepatitis. This doesn't fully show the picture, but we know that it's still impacting rural communities. And there was some data several years ago that showed these rural counties that were highly impacted by both HIV and Hep C, where there were likely to be outbreaks, and we're still seeing increases in rates of acute Hep C in a lot of the rural areas of the United States. Okay, so next slide. And then I also wanted to just point out that the viral hepatitis in general, but also Hep C, continues to most severely impact Black, Indigenous, and people of color communities. So as I mentioned before, the rates of acute Hep C most recently reported in 2020 were highest among American Indian and Alaska Natives. And also, while rates for almost all race and ethnicities increased in the last couple of years, rates among non-Hispanic Black people increased by 57% compared to 14% increase among white non-Hispanic population. So again, just to point out that certainly the communities of Black, Indigenous, and people of color communities are most impacted and continue to be most impacted by hepatitis C. So next slide. As we're talking about testing, and I was happy to see and interested to, well, not happy to see, I shouldn't say that, but interested to see what Marcus put in the chat before about testing decrease in the state of West Virginia, because it's great to get some of these anecdotal pieces of evidence where CDC is putting out a lot of national data and saying, be careful, in your interpretation of this, because we know screening and linkage decreased. Health HCV actually was in the midst of convening a learning cohort as the pandemic swept in 2 years ago. And we actually have some data to show that of the sites we were working with, that there was a significant, drop in screening and linkage to care. And there's one outlier you can see, I think it's site 2, where they actually dropped from their first to the second quarter, but then increased their screening significantly following a lot of the shutdowns. They were also a large hospital system. But just to give you some context, that the sites we were working with were primarily aid service organizations and community-based sites, community-based organizations. We did work with one outpatient treatment organization as well, substance use treatment organization. And pretty much all of the sites had a decrease in testing numbers very significantly, from 43% up to 100% decrease in testing, especially from the first quarter. So that would be January to March 2020, and then March 2020 into through July 2020. Of course, a significant drop. And even 4 of the 10 sites that we were originally working with stopped screening entirely almost throughout the entire year. So I just wanted to point this out, that was really, kind of an aha for this. And I do want to note that within our cohort, the positivity rate, even though testing decreased, the positivity rate did not change significantly. We did see a very slight increase among some sites and a very slight decrease among other sites, and some stayed the same. So, I just wanted to share that I do think a huge impact was in the screening and linkage to care piece that really dropped off. And what we're all anticipating is seeing from 2021 data that rates of Hep C will go up. The data will show that, certainly, because of the reduced linkage to care and because of the reduced screening that happened in 2020. So we can go to the next slide. So I just wanted to, again, just go back to the CDC data, just to say that, there's some other data on chronic Hep C where infection is the highest. As I mentioned, new cases is increasing between ages 20 to 39, but we're still seeing chronic Hep C among the baby boomer generation 55 to 70 now. And I also just wanted to point out something along related to the HCV associated deaths, which are going up. And also, knowing that with COVID, the overall age-adjusted death rate in the US was impacted. So we have to take some of this data into consideration when we're looking here. But again, pointing out kind of the impact on specific race ethnicities, that death rates among American Indian, Alaska Natives, and non-Hispanic Black persons was much higher than non-Hispanic white persons. So I see somebody put out in the chat, accounting for the increase in Hep C among Black communities. That's a really great question, and I don't know that I have a specific answer to it. But that's something certainly folks need to look into. We have seen rates increasing among all populations. I don't know that I don't know what the exact difference is in terms of service, but we do know there's certainly issues related to health equity, racism, stigma, a number of factors that come into play that we can attribute to the likely increase in Hep C in Black communities, and just access to services, especially when we're thinking about minority populations such as American Indians and Alaska Natives, and access to services. So there's probably a number of reasons, and I would love others to chime in the chat. If you have some specific information or data to share on that. Okay, we can go to the next slide. So I just wanted to point out before we wrap up, just sharing some of this data, or discussing some of this data here, that I think there's kind of a reset that needs to happen when we start to think about where are we with meeting some of these national goals. And alongside some of the surveillance data that was put out recently, there was also data showing our progress as a nation against some of the viral hepatitis goals that were set. And I specifically just pulled out the goals on Hep C. And as you can see from what I pulled out here from the most recent dashboard, we are still far from our 2025 targets, and 2025 is around the corner. And it's really even harder, and it's harder to even assess the progress until we kind of get out of this COVID eclipse, or kind of COVID era, where all the data, and even monkeypox, I should say, I should add that in, that it's very challenging on the public health system to determine kind of where we're at. But with that being said, it's more important than ever that we continue to increase the hepatitis C services, so that we can meet some of these 2025 goals. So I just wanted to put that on the screen so you could see. And we can go to the next slide. Great. So I wanted to just start this section after kind of sharing some surveillance information by talking about clinical provider practices. So Health HIV conducts a number of annual state of surveys, our state of HIV, our state of Hep C. We look at aging and HIV and a variety of other services. So we did look at clinical provider practices last year, and especially kind of looking at what happened after the COVID-19 pandemic. And given some of the data that just came out, I think this will be more interesting than ever to kind of compare what the providers have said versus what we're seeing in the national data. So there's almost 400 individuals that provide Hep C services or work in Hep C, or in organizations that provide hepatitis C services, that completed this survey. And I'll just go into some of the data on it. So we can go to the next slide. Awesome. So one of the ahas that came out of this, or kind of the salient points that came out of this survey, was that we were still seeing that many hepatitis C service providers are not implementing the 2019 hepatitis C screening recommendations. And I think, we have to, the caveat of, reduced screening overall needs to be taken into consideration. But that being said, many of the service providers, or the clinical providers that responded to this survey, were not screening all adult patients at least one time, which is the CDC recommendation. Many were still just simply doing risk-based screening. And we also were interested to see that some of the provider respondents said they're not screening all baby boomers, which again, as I pointed out, was the one of two age groups that are still experiencing chronic Hep C at the highest rates, and that almost half were not screening all patients with HIV, and fewer were screening patients pregnant in their third trimester. So all areas where the CDC has provided guidance, in their expanded screening guidelines and recommendations. So we're not seeing that providers are doing this across the board. It it just shows there needs to be more advocacy, more education, more awareness around guidance, guidelines, and Hep C screening just in general. So next slide. We also asked, where the providers thought that increased screening would be most beneficial. And I think a lot of us that work in community-based organizations or with community-based organizations can agree on some of these, because we know that people living with Hep C may be accessing other types of services. They might be visiting a private practice for primary care. They might be engaged in harm reduction services and be visiting a syringe service program or needle exchange center. They might be in a treatment program, and they might be also living with HIV. So all 4 of these settings, HIV care and treatment programs, substance use centers, needle exchange centers, private practice, this is where providers felt that it was important to increase screening. And I think from the data that Health HIV has seen, private practice has a ways to go with, especially with universal hepatitis C screening. And I think that, needle exchange centers and substance use treatment centers tend to be a bit more engaged, just from what we've seen on the ground, and even HIV care providers. So how do we engage primary care providers and primary care associations and others to really increase and standardize universal screening for hepatitis C? I think that's an important area for us to focus in to increase screening. So next slide. And then in terms of service delivery model, we asked kind of how providers are providing or are delivering hepatitis C services. And there was 3 kind of key models that came out, which was co-located on-site model, where providers are providing both hepatitis C screening, linkage, treatment, all in one site. And then also on-site and referral models. So that is the provider is delivering maybe just screening and linking out or referring out to a treatment provider. And then lastly, kind of the ECHO model, which is the telehealth-based collaborative management model, where providers use telehealth to engage with hepatitis C or infectious disease specialists to manage individuals that are on Hep C treatment. I think one messaging that we'd like to continue to promote and advocate for is really this idea that, and something Health HIV has always really been a proponent of, that primary care providers can treat HIV, they can treat hepatitis C. It is not a specialist. It's not necessarily necessary for a specialist always. And of course, we see, there's circumstances where a specialist is required or can be beneficial, but hepatitis C can be easily treated in primary care. And we need to continue to get that message out, that you do not need to engage a specialist always and refer out. And we need to increase training and education among primary care providers, especially in screening, but also in treatment, because keeping individuals in one place, a one-stop shop model has always been the most effective in engaging and having successful treatment. So wanted to point that out here. We can go to the next slide. All right, so we did see some providers reporting reinfection among Hep C. And again, this just kind of, brings up some questions around where we can do better provider education and patient education. And this is all self-reported from providers that they were seeing HCV reinfection among people who inject drugs, people experiencing homelessness, and people who are co-infected with HIV and hepatitis C. So this is what they're experiencing in their practices. I think it's important to just consider, again, where we can provide more education to these patient populations and to providers around reinfection. And we do know that the kind of perceptions and in some cases misinformation around reinfection, especially among injection drug users, is pervasive in some provider populations, and that we want to make sure that there's accurate data on this that we can share, and also make sure that providers know that the potential threat or concern of reinfection does not it is not a reason to not treat any particular individual, whether they are actively using drugs, experiencing homelessness, or co-infected with HIV. So we just want to make sure those messages again are being shared clearly. We can go to the next slide. So interestingly, in comparison to what we saw from some of the CDC, or more significantly than what we saw from the CDC data, is that a lot of the providers in 2021 said they had experienced an increase in patients diagnosed with Hep C. I think, again, once we, in a year from now, once we get some new national level data on hepatitis C infection, we might be able to look at this and see if providers were right. Will we see in the 2021 data almost a 30% increase in patients with Hep C? It's possible, and it's certainly, to me, kind of alarming in a way. If this truly is the case, we're going to see a significant need to scale up care as we see more patients diagnosed with Hep C. And we're going to need to expand the provider workforce significantly to treat people who are newly diagnosed with Hep C and other infectious diseases. So this is certainly an important consideration for us as we start planning, planning advocacy, planning, education, training in the next few years. Some of the providers reported they were able to continue to provide Hep C care via telemedicine. However, a lot of them had to either halt services altogether, which is something we saw in our cohort, and others still had to reprioritize away from Hep C services. So increasing, for example, COVID-19 screening versus hepatitis C screening. So shifting staff away from Hep C service delivery was something that was reported. We can go to the next slide. Great. So we still see that a number of reported barriers to Hep C care tend to be structural barriers. And one of them being that they're just still, internally in a lot of these settings, there's limited infrastructure for providing services, whether that is staffing, workflow, effective policies, et cetera. That the administrative time for processing prior authorizations and pre-approvals can be a barrier. And then, of course, as we've been talking about, and Jen was highlighting, the treatment utilization policies, payer coverage, national and state level policies that impact a provider's ability to treat patients. And then at a client level, it's slightly different, where barriers to Hep C care might be social, lack of knowledge, of course, costs, lack of symptoms and other comorbidities, and substance use associated comorbid conditions. So we can go to the next slide. As far as facilitators, what providers were reporting was that co-location of wraparound services and hepatitis C care services can be a huge facilitator, is a huge facilitator to Hep C care. That might mean co-locating hepatitis C care and treatment with screening, with substance use treatment, housing services, a variety of other wraparound services that might be available. So that's something that, again, kind of the one-stop shop model continues to be extremely effective. They also said that having more training and resources, and then also the simplicity of direct acting antiretrovirals and simplified hepatitis C treatment algorithm as well were facilitating their ability to provide hepatitis C care. And then for clients, having access to trustworthy providers, culturally competent care, again, mentioning the co-located models, and being able to pay for their Hep C services, and also having the ability to access a navigator or receive navigation to cover those services with their insurer. Next slide. We also saw that in terms of funding for hepatitis C services, that a lot of the services are covered via government grants, about a third through billing with insurance, and then 10% were clients or patients self-pay. It was I think interesting to me, which is why it was pulled out here, that a lot of the provider respondents do not currently use patient assistance programs. And I'm not sure if that is awareness issue, or if they're utilizing other methods of payment, such as going directly through insurance, which is possible. But that's just something interesting for us to consider, and possibly make sure that that information is more widely available, that there are patient assistance programs that can be accessed. Next slide. And then in terms of payers, I think, we continue to look at the challenge that providers might have, the inability to treat a patient with Hep C that could be due to payer or insurance restrictions. And, this has been pretty significant, I think, over the past 5 years or plus that we've been doing our State of Hepatitis C Care survey, that we always see that these providers are unable to treat patients. This past year, it was just about 30% that said that they have had that a payer or insurance restriction caused them to be unable to treat a patient in the last 12 months. So again, it's still something that needs to be a part of really the state level advocacy. And, something that we can do is really look at, of those 30%, where are they located, and do a little bit of a deeper dive into that. Might be interesting to compare to some of the data and policy information that Jen shared earlier. And so wanted to just put that out here. We can go to the next slide here, Jen. Awesome. And then in terms of training needs, this just indicates, again, kind of the screening guidelines, the treatment guidelines. These are all requested as training needs by the provider respondents, simplifying Hep C care and treatment, enhancing linkage to care, and discussing substance use with patients with Hep C. And I think from what we've seen and what I've seen anecdotally is still the biggest gap that we have in the Hep C care continuum, if we call it that, really is the linkage to care piece, screening and linkage to care. We know that we have effective treatments to cure people with hepatitis C, that are manageable, that are, relatively short term. And so there really is no reason why we should be seeing such increases in hepatitis C when we have curative therapy. And it's really just because of the lack of screening, and then also, once screened, the lack of linkage to care among individuals diagnosed with hepatitis C. So I really think, as national organizations and local organizations, it's where we need to put our focus is on increasing these screening and linkage to care. So next slide. So lastly, I just wanted to point out, as I wrap up, some implications from this this most recent survey, that we are anticipating more hepatitis C patients entering care. I'll be really interested to see, kind of, once we start to get more data, and I think there is some state level data already where we're seeing some increases. Actually, I think it was a state of, I don't know if there's anyone from Michigan on the line today, but I think I was looking at a report from Michigan, I believe, recently, their 2021 data that they've released. So I know a lot of states have released their 2021 state level data. And in Michigan, they were seeing significant increases in people diagnosed with Hep C, and also, in individuals, morbidity and mortality related to Hep C as well. So I think we'll continue to get that data and have to sift through it, and use those as advocacy points, or ways to advocate to increase screening, to increase linkage to care. In order to accommodate what we are likely going to see and are already seeing in terms of hepatitis C patients entering care, we're going to certainly have to increase linkage and navigation services and administrative capacities in these settings, and integrating harm reduction services, wraparound services. So there's a lot that needs to be done in order to meet the needs of these patients entering care, and certainly a lot that providers can engage on, and where we as advocates also can make the case for better policies and structural interventions that can support patients entering care and providers being able to effectively treat these hepatitis C patients. So you can go to the next slide, Jen. So if you're interested in looking at this full report, it is on Health HCV's website. There will be some more data coming out for this year, upcoming, probably towards the end of the year, as we've been fielding a number of smaller surveys around hepatitis C care and a variety of other and HIV care and co-infection as well. So we'll be very happy to share all of that with you all as that becomes available. But in the meantime, if you'd like to reach out to me for any questions about this data or anything I shared, my email is on the screen here. And I think now we can transition into our Q&A period.
Thank you so much, Marissa. That was awesome. I'm going to go ahead and stop the screen sharing real quick, because yay, faces and things like that are prioritized. A couple of notes, because ideas pop up, and Jada asked a question that I absolutely want to get to, although I'm not sure that I'm the guy to answer it. Patient assistance programs, real quick. A lot of reasons, well, I won't say a lot of the reasons. What I will say is that when a drug goes generic, the patient assistance program that's typically associated with manufacturer tends to stop. That doesn't mean it happens in all cases, but if a provider is prescribing for a generic, there may or may not even be a patient assistance program that's available. That doesn't mean that there's not other funding opportunities. 340B dollars, for example, for covered entities should be directed to help covering these costs for patients who are having a hard time accessing or affording their medications. I did want to talk very, very briefly about telemedicine as an opportunity and these one-stop shop ideas, especially for the folks on the line that might be a provider entity. This is not necessarily a bad thing. It's absolutely a great thing that a patient go in one place and get everything they need. That does not mean that it is a sole entity working in a sole site. Oftentimes, providers are very good at providing medical care. That doesn't necessarily mean that they're very good at providing housing assistance. The idea that we can be everything to everyone and be good at it is not necessarily good. For patients that need diverse opportunities or have diverse sets of needs, and especially as we look at that as a potential consolidation of access to care for patients, especially in rural areas. So you're talking about, hey, we might have a housing resource that's 20 miles that way, and we've got a clinic here, and all of those other things, and you've got spread out patients that can't necessarily meet like in all of those different spots. But if that means that everything that they need is suddenly 50 miles more away and they don't have transportation, that's a problem too. So the best way to meet these needs is going to be dependent on those communities. And I think we really need to be mindful about that as we look at these different models of meeting needs for patients. That said, if you have questions, if you have comments, you want to contribute to the conversation, again, I'm going to encourage you to pipe up in the chat, and you're also welcome to raise your hand. I will go through and work to unmute you or send you an opportunity to do that. But Jada had asked a really well, I won't say interesting. It's a pertinent question. It's prescient, which is what is accounting for the great increases in hepatitis C in Black communities? And as a white trans guy, I don't know that I'm the right one to answer that, quite honestly. My lived experience, even as a recovering addict and person living with HIV, is going to be very, very different from that of Black people in Black communities. Even if I have spent the majority of my life in majority minority studies, it doesn't matter. I'm still a white dude that's going to be taken more seriously by my provider, regardless of how much money I make or who my payer is. What I will say is that Marissa hit the nail on the head talking about the systemic nature of racism and how that furthers disparities and barriers to care, and really all of those social ills come to a head and they manifest themselves in all kinds of health metrics, including overdose, including hepatitis C, including HIV, including COVID and monkeypox, and everything else that we see going on. Maternal mortality. We're just opening our eyes a little bit more. It doesn't mean that society is ready to deal with it, and I think that's shameful. I think it's something that when we talk about moral ills and social ills, that's one of them. Addiction itself and substance use itself is not. So, anybody else? Comments, questions, Marissa, feedback?
Yeah, I would love to, and also just to know, I would love to hear, if anyone has on the ground experience. It's unfortunate we share this national level data sometimes, and you don't get the on the ground stories as much. So if there's anything you have to share, I would certainly love to hear it. And I just wanted to mention something that I think Jen put in the chat about ER groups, and actually when I saw that you put that in there, Jen, it reminded me of the cohort that I was sharing that we worked with during 2020. One of them actually was an emergency room where they were hoping to increase screening and linkage to care, and the challenge that the administrator was having of the ER was really getting buy-in on the kind of C-suite level, so the higher level administrators to engage in expanding their policy and expanding their hepatitis C screening. And one of the ways that she was able to kind of make the case was we were sharing some of the data and rationale that CDC put forth with their expanding screening recommendations, which is the kind of cost effectiveness of hepatitis C screening. And so we know that a lot of larger healthcare entities are more motivated by the dollars and reimbursement and cost savings. So just to share, as you're advocating in your community, possibly around increased screening in ERs, that, and then one of the incentives really is in long-term cost savings, to do these screenings. So CDC has some great data on that came out. It's all referenced in their screening guidelines that came out in 2019. So I just wanted to share that.
Well, and as I encourage advocates to start engaging, if they haven't already, engaging in their state Medicaid programs and on that level, one of the best ways to deal with that is looking at hepatitis C screening, especially the opt-out policies and statutes, and to pair that with the standard of care. To say this is required in order to get a reimbursement, and you will be penalized for not doing so. Your state CMS coordinator can absolutely determine that as policy or rule regulation that is required and will incentivize. And quite frankly, when you start talking to administrators about dollars and cents and you say, hey, you're going to be penalized for every patient that you don't screen for hepatitis C, they're going to start moving. They're going to motivate their providers. So there are regulatory solutions. There are private solutions. If private payers are turning around and going, hey, we're going to give you problems about your reimbursement because of this, then know there's partnerships to be made, and progress that can be made through that type of advocacy. And certainly we're here to help support those things, to brainstorm, to say, hey, we saw this happen somewhere else and it was great. That's part of what we do. All right, I'm going to give it a couple of moments for folks if you want to raise your hand or ask any questions. I do understand that's a lot of information. Everybody's going to a lot of meetings. Like if you're a little tired on that, we absolutely respect it, and we still love and appreciate you for coming. I do want to say thank you for coming as participants to this. I also want to point out that our sponsors, ADAP Advocacy Association, Gilead, Janssen, Merck, ViiV, as funders, at least for CAN, we don't ask patients for dollars to fund this kind of work. And it's really important for us not to do that, especially when we recognize the disparities that communities are facing. So this work is possible because of our funders and the dynamic relationships that we have with them. So thank you for helping us to give voice to people who have a hard time getting heard. That's our job, and y'all are helping us do it.
Yeah, that's great. Just one little plug to put in people's ears as they walk away to, or a thought to put in your ear is, I'm sure everyone has been engaged in some way or another in looking at some of the new long-acting HIV treatments. And I think it's interesting for us to think about, for co-infected populations, how that might positively impact individuals that are living with hepatitis C, or not, or how do we engage individuals who are co-infected in long-acting antiretrovirals? Is it the right thing to do? I think as kind of the science is evolving in HIV and also in Hep C, we have to continue to take into consideration what are the patient perspectives, and where can it benefit some of the populations that we work with. So just wanted to put that out there as a thought for everyone. Now that we're seeing all of this data coming out on long-acting antiretrovirals, where does the co-infected patient kind of fit in, and how will that impact them? So just a thought, and thanks, Beth, for sharing that data. That is incredibly high, and very interesting.
Any other thoughts anybody would like to contribute? You don't have to either. Again, I totally understand, like, virtual meetings are hard, especially when we miss each other as advocates, and getting together is kind of hard, but you're also juggling other work. And again, we really appreciate y'all taking the time to come today. All right, with that silence, I'm going to wrap up. I will leave our sponsor screen open for a little bit, and I'll hang out for a little bit. If anybody wants to chat briefly and quiet and privately, you're welcome to do so. But thank you again from Community Access National Network and Health HIV for attending the 7th Annual Monitoring Report on HIV and HCV co-infection.